This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app. Today's podcast is on ALIF, anterior, lumbar, interbody fusion. Anterior means going from the front. So to get to the spine, we're actually going to go through your abdomen and go in from the front. It sounds pretty crazy at first, but I'll explain why it's a very effective way to get a fusion. The ALIF, the next letter is the L, lumbar, which means your lower back. The IF part stands for interbody fusion. What interbody means between the vertebral bodies, which is what the disc is. So essentially an interbody fusion means take the disc out, put bone in the disc space, and get the two vertebral bodies to fuse through the disc space. And fusion obviously means fusion. Fusion literally means we want the two vertebrae to fuse together. We want them to grow together. So we're going to get rid of the disc or the facet joints in the back, which are the mobile component. They're a joint just like a knee or a hip joint. It's where motion occurs. We're going to get rid of the motion segment, get bone to grow across the joint or the disc, get the two vertebrae to fuse together so they never move again and they won't hurt anymore. That's what ultimately stops the pathology such as degeneration, multiple herniated discs, a spondylolisthesis, a scoliosis. The deformities primarily occur through the disc because that's where all the motion is occurring. Therefore, the fusion corrects where the pathology is, which is through the disc space and through the facet joints in the back. For example, a fusion at L4, L5 means we're getting rid of the disc and or the facet joints between the vertebra at L4 and L5, putting in bone and getting those two vertebrae to fuse together. So a motion segment has two numbers. That always confuses people for a long time. But a motion segment, the disc or the facet joints, is L4, L5, which means fusing the L4 vertebra to the L5 vertebra. So why are we going to go in the front? Most back surgery, everybody thinks of a scar right in your back, and they do the surgery in your back. And that's how fusions were done forever, for the past 50 years. Until really the past 20 to 25 years, fusions were all done from the back. The problem with doing the fusions in the back is you're essentially trying to fuse the facet joints. So for every disc in the front, you have two facet joints in the back. Well, only 20% of your weight and your loading goes through the facet joints. 80% goes through the disc. So that's where all the biomechanical activity and stress and weight bearing is occurring. So that's where all the action is. So if you really want to fuse this motion segment, you got to get after the disc because that's where all the action is. If you just fuse somebody posteriorly, which means from behind or in the back, the chance of a successful fusion has traditionally been around 60 to 70%. That means that you try the surgery, you attempt to do a fusion, you put bone back there, maybe put some screws and rods in, but only 60 to 70% of the time does bone actually grow between the two vertebrae, for instance, L4 and L5, and that the motion is actually stopped. Well, that's one reason why there were so many failed back surgeries 20, 30 years ago, because the surgeons attempted to do a fusion but didn't actually succeed. These days, at least in our practice, almost every lumbar fusion we do an interbody fusion, which means we're going to take the disc out and put some type of spacer into the disc space with some type of bone product and then get some fixation. Put some screws and rods or a plate or screws through the graft. We're going to stop the motion with metal screws because there's a couple things you need to get a fusion to occur. First of all, fusing the disc space, you have to get rid of the disc. You have to clean all the disc material out, get the cartilage off the bones so that you only have left two bones, the L4 and the L5 vertebra, for instance. Then you've got to put a spacer in that's going to provide stability. So you've taken out the disc. Well, you can't have the two bones collapse down together or flop around. So you put a big spacer in. The spacer can be made of metal, plastic, or bone. And they all work similarly. We tend to use plastic, but we use different devices for different reasons. So first, you get rid of all the disc material and cartilage, so it's just bone to bone. Then you put a big spacer in to provide stability between the bones. It locks the two bones in place because you actually preserve some of the disc, especially on the outer margins, and the ligament, which connects the two bones together. So as you jack the bones back open, the ligaments that are still intact provide like a check rein in order to provide stability, so when you wedge the spacer in between the bones, it stays in place. Then you can provide some fixation like metal screws to really lock it in place. So first, get rid of the disc. Second, put a big spacer in to provide stability. Then the third component is you need to stop the motion. And stopping the motion usually involves some types of screws. And there's a lot of different varieties. We can put screws through the plastic spacer. We can put a plate with screws from the front. Or we can go in the back and put in pedicle screws with rods in the back, which is the most traditional and the strongest type of construct. And the principle is you have to stop the motion to get bone to grow. You know, if you break your arm, what do? You put a cast on. Well, the cast stops the motion. If you didn't put a cast on and you still had motion occur through the fracture, your body would just make another joint out of it. So you have to stop the motion, like with a cast, to let your body form bone. And the same thing in the spine. If you want to do a fusion, you have to get rid of the disc or get rid of the facet joints, put some type of bone product into the space, and then stop the motion with usually metal fixation. And then the fourth component is, what are you going to put in the disc space? Are you going to put a protein, a biologic, cadaver bone, the person's own bone? Generally, we'll put some type of product into the disc space which will help stimulate your body to make the bone. And your body literally brings bone cells in, it brings proteins, it brings blood, all these things to basically heal the fracture site. You've essentially created a fracture or a broken segment through the disc space, and now you're trying to encourage the body to heal it with fixation and stability from the screws, with a big spacer to provide stability, and then some type of biologic to help stimulate the body to make the bone. One of the great things about living in America, but also it can be confusing, is there are so many options. Surgeons have such a wide variety of options of how to do a fusion, to go from the front, the side, the back, a combination of multiple ones, what type of spacer to put in, what size, what type of fixation. For a single level fusion, there's probably 100 different combinations of potential surgeries that all can have good outcomes. But I really empathize with patients who have this bad back and are trying to make a life decision, and they're so uneducated because obviously you're not a doctor, and there's so many choices. You go on the internet and you just see picture and video of one after another. There's so many options, it's got to drive people crazy, because as a spine surgeon, it takes you about 10 years to really understand all your different options and what's best for each individual case. And I can tell you in our practice, we really try and know how to do every surgery with every type of device and technique. Therefore, the patient's pathology, whatever the patient's problem is, determines what we're going to do, because we know how to do just about everything. Whereas, quite frankly, a lot of surgeons can get locked into a zone where they kind of do the same surgery for every type of problem. And one of the great things about American medicine, at least today, is we have a lot of options, where if you're well trained and experienced and put your research and your time in, you have a wide variety of ways to treat a problem depending on what the patient's primary problem is. And the basic principle is, what's the least invasive surgery and safest that we can do that's going to fundamentally correct this problem the best? So back to the ALIF and going in the front, the anterior approach. So I know it sounds crazy to go through somebody's stomach to get to the spine, and everybody looks at me like I'm crazy when I suggest it to a patient. But in reality, if you look at a spine model, the disc is in the front. So if you want to get to the disc and correct the problem, going in the front gives you the best access if you can safely get down there. Most of the pathology occurs through the disc space. So the disc collapses down as we get older. As you get degeneration and bulging of the discs and herniations, the disc collapses down. Well, the worst thing you can do is to fuse somebody in that collapsed down position. because when the disc collapses down, you lose your lordosis. Your lordosis is what allows us to stand up straight. It's that normal curvature to your lumbar spine. Well, as the disc collapses down, you get more and more bent forward. That's one of the reasons why as we get older, we all get more and more C-shaped and bent forward and collapse down, is because we've lost a lot of the height of the discs due to degeneration, arthritis, wear and tear. It's all different terms for the same fundamental problem. So what we don't want to do as a surgeon is to fuse somebody in that collapsed down space where they're kyphotic or have lost the lordosis, where they're bent forward. You don't want to fuse them locked in that position, because then their whole torso is jutted forward on their pelvis and on their legs, which makes their whole upper body and torso weigh more effectively, and which puts more stress on the discs and more stress on the whole system. So when we fuse people, we want to correct that loss of height of the disc. We want to jack it back open and restore the lordosis to bring their whole upper body back over their hips to put them in a better position for the long haul. So going in the front allows us great access to the disc. It allows us to get all the disc out, get all that cartilage out, to really get just bone to bone, have a great fusion surface area, which increases the chance of a successful fusion. Then it allows us to put a big spacer in from the front, and we usually use a wedge-shaped spacer, which is bigger in the front and smaller in the back. Cut 6, 12, 18 degrees, whatever we need to jack open the front to get the lordosis back. Also, it allows, by opening up the disc space, it indirectly opens up the foramen, which are the holes where the nerves come out. So if you have a pinched nerve, by jacking the disc space back open, it can take the pressure off the nerves. So going anteriorly is a great surgery from the spine perspective. As a spine surgeon, I know I can get great correction of the pathology, of the malalignment, of all the problems that have developed over the years. In an hour surgery, we can jack it back open through a very safe approach and really fundamentally biomechanically correct the spine. One of the reasons why people don't go from the front is because of the risks. Going in the front, you've got to have experience to do that. We use a vascular surgeon who's an access surgeon. He specializes in getting down to the spine, because there are blood vessels that sit right on the front of your spine, your aorta and your inferior vena cava, that go down into your legs. Those are big arteries and a big vein that you don't want to disturb and don't want to have a complication from. You also obviously have your bowels. Now, one of the things is we don't go through the stomach. So we actually make the incision around your belly button. We don't cut the rectus muscle. So minimally invasive surgery basically means don't disturb the muscles as much as possible. So if you don't cut the muscles and you go around the muscles, that's considered a minimally invasive surgery. And when we go in from the front to do these ALIFs, we don't cut the rectus muscle. We go around it. And basically, all of your organs, we don't go through your stomach. All of your organs and your intestines and everything are contained in a sac called the peritoneum. And we basically go around that sac. We typically go in on the left side of the patient and then move the sac to the side. Then our vascular surgeon deals with the blood vessels and moves those out of the way to get us access to the spine. And he puts retractors in that holds everything out of the way. If you have a good approach surgeon, a lot of times it can take them 10 to 15 minutes to get down to the spine, put the retractors in, and make my job very easy. Because my job typically is to take the disc out, clean all the cartilage out, put the right spacer in, get the right size in with the appropriate correction, and then lock everything in place. But just like every surgery, there are obviously potential complications, and an anterior approach has a lot of potential complications that any surgeon who's done a lot of has had complications. That's just part of the deal. There's potential injury to your bowels and your organs, as well as the blood vessels, sexual dysfunction, weakness, numbness, everything you can imagine can potentially happen. But overall, if somebody does a high volume of anterior approaches and has a lot of experience, it typically can be a good surgery that really corrects the fundamental spine problem. So there are two different ways in general to do the anterior fusion. We either call it a standalone, which means we're going to go in the front, put the spacer in, probably put some screws or some type of fixation, some stability from the front, and that's it. We call that a standalone because you're just putting the graft in and that's it. That's one way. The second way is to go in the front, do the anterior fusion, but then to close that, to turn the person over typically. Sometimes we do it at a later date, but typically we do it the same day, same anesthesia. We flip the patient over and go in the back and put in screws or some type of stability from the back. Now, basically, the screws in the back are the strongest. They're called pedicle screws. And if you ever see an x-ray or see them in real life, they're about 4 to 5 centimeters long and about 0.6 centimeters in diameter. So they're big screws, and rods lock them in place. But to put the screws in the back, involves some type of muscle dissection, which can cause pain and make physical therapy more prolonged and potential other issues. So going in the front alone is less invasive because it involves no posterior muscle dissection, no surgery in the back. And we call that a standalone when it's from the front alone. Reported fusion rates from doing it from the front alone for a single level case, a one level fusion, is about 90 to 95% fusion rate, which is an outstanding fusion rate. Now, one thing that's important to define is fusion rate versus clinical success. So when I say fusion rate, I'm talking about bone growth, like say L5S1 or let's stick with L4, L5. If we're trying to fuse L4, 5, after you do the fusion surgery, 6 months, a year after the surgery, we can get a CT scan and analyze, is there connecting bone? Has bone grown between L4 and L5 with a solid bridge? Therefore, is there a fusion? Are those two bones fused together? And that's considered a fusion rate of 90 to 95%, for instance. The other definition is a clinical success rate, which is typically not as high as the fusion success rate. So we may get 95% of people to fuse, for instance, but only 85% get a clinical success rate. Clinical success is considered a significant reduction in pain or a significant improvement in function that basically makes it worthwhile for the patient to do the surgery. An easy way to summarize that is if you ask the patient 1 year, 2 years out from the surgery, was it worth it? Would you do it again? Did you get enough improvement of your pain or improvement of your function that it was worth it and you do it all again? If so, that's basically a success. So the difference is you may have a successful fusion. You might have gotten successful bone growth. The two bones are fused together, they're stuck together, they're not moving, but you still have a lot of pain. And that's one of the downsides of having spine surgery is sometimes the surgery mechanically goes well and everything is a success, but the patient can still have pain. And the reason why is they may have permanent nerve damage from the pressure on the nerves for so long before the surgery. They may have a complication from the surgery that caused them to have more issues even though they still got a successful fusion. Also, if you fuse one segment, it can put more stress on the other levels or on your SI joints or your hips or the other discs in your back, and you may have pain from those levels. So there's a multitude of reasons why you may still have pain even though you've had a successful fusion. So we mentioned that the standalone ALIF has around a 90 to 95% fusion rate, and you've got to do a literature review based on exactly what your situation is and what device is being used and how many levels are being fused, but that's a general estimation from the literature. Now, why does it not fuse? Well, because the fixation from the front generally is not as strong as the fixation you can get in the back. And that's what leads us to the anterior-posterior fusion combined, where we go in the front, put the spacer in from the front, and then go in the back and put in the big screws in the back. And the pedicle screws we put in from the back are just flat out bigger than the screws we put in from the front. They're about twice as big, and they provide more stability and more fixation than the ones from the front. Now, sometimes the one in the front are big enough and strong enough to get the fusion, but the ones in the back are basically bigger and stronger. And so an anterior-posterior fusion has a higher fusion rate, higher chance of overall bone growth, but it does involve some type of muscle dissection in the back. And there's two different ways that we can put the screws in the back in general. Again, there's probably 1,000 different ways, but in general, you can either put the screws in open or percutaneous. Open generally means you make a midline incision, a scar right down the middle. You detach the muscle from the bone and you pull the muscle back to the sides and put the screws in. The downside of that is by detaching the muscle attachments to the bone, it decreases some of the muscle function. Also, to get the angle that you need to put the screws in, a lot of times you have to expose some of the blood supply and the muscle supply to the facet joints at the level above and or below the one you're fusing. So say we're fusing L4-5. Well, I don't mind disturbing the blood supply and whatnot at L4-5 because we're fusing it. But we don't want to disturb L3-4 or L5-S1, the one below it, as much as possible because we want to save as much function of those. We may have 10, 20, 30, 40 years of this patient to live. We want to save those other levels as much as possible. So we want to preserve the blood supply and the muscle supply. And doing an open approach may disturb more of the muscle and blood supply to those other facet joints, in addition to detaching the muscle attachments from the midline. So an alternative we call percutaneous, which can also be considered a Wiltse approach or more of a lateral approach, where we'll actually make 2 incisions off on the sides, one on each side, the right and the left, and work through the muscle, dilate a hole in the muscle, and put the screws in. We call it percutaneous because it means from the skin, where you're not opening everything up and you're not exposing all the spine. You're doing it less invasive. You're doing it a little bit more blind, in which case typically surgeons will rely on some type of x-ray, fluoroscopy, or computer navigation. We actually use a computer navigated system, which is amazing. It actually gives us a 3-dimensional picture of the spine in the operating room, and this computer shows us where our screws are going to go in relation to the spine in real time. It's like a GPS fighter system. As I move my hand and I move my instrument, the projection of where the screw's going, I see it on a 3-dimensional picture. So I can see where the bone is that I want to put the screw in and where the nerves are where I don't want to put the screws. And there's so much different technology out there, and the technological advances that have been made in spine surgery are remarkable over the past 10 to 20 years that makes putting the screws in safer and faster, and it allows us to do it less invasive because if we have a 3-dimensional computer picture, we don't need to open everything up. We can rely on that and some other checkpoints to know where we are to put the screws in safely and less invasive. So the screws in the back, the pedicle screws in the back, increase stability, which increases the fusion rate, and it also helps preserve the correction we've gotten and helps us get a little bit more correction. So if somebody has a scoliosis where they're tilted to one side, or if they have this kyphosis where they're collapsed down in the front, or if they have a spondylolisthesis where the 2 bones have slipped in relation to each other, the pedicle screws in the back can help us correct more of the deformity and also lock it in place and preserve it. So results of the surgery, and these are in general our results of the surgery, and which is typically found in the literature as well, is that the anterior fusion, the standalone ALIF fusion, generally people stay in the hospital for 1 or 2 nights. They're up and walking right away. And typically they'll go home after 1 or 2 nights in the hospital. We tell everybody, plan on taking 2 weeks off, where nothing's really expected of you for 2 weeks after the surgery. You can walk around and sit and talk and even go out to eat if you feel like it, but don't have anything expected of you. No meetings, no appointments, no driving. Just take 2 weeks off of your life, which sounds crazy in this day and age, but it's still surgery. Take 2 weeks off. Take a break, walk around. We see people back 2 weeks after the surgery. We take x-rays, we see how they're doing, and we slowly progress their activity with increased walking until we start the physical therapy. Now, it takes 3 to 6 months for the bone to grow and the fusion and get solid. So we're not in a rush to do the physical therapy and get people back to their sports and activities because we got to get the bone to grow. That's going to determine the real success of the surgery is, do you get a successful fusion and successful bone growth? So we don't want to mess that up. So generally we start the physical therapy around 8 to 10 weeks after the surgery. First 8 to 10 weeks, we just want bone to grow and to get some stability. And the physical therapy, it's the same program that we have on the Back Doctor app, our 5-level back exercise program. It starts in neutral position where you're less likely to aggravate things and you work your way up with balance and coordination. But we always recommend you do the whole program with the physical therapist after the surgery. You need a trained professional to watch you do the exercises and make sure you do them properly. So the anterior-posterior fusion, people typically stay in the hospital about 2 nights. It may be about half a day longer than just the anterior alone. because doing the muscle dissection in the back can cause more pain. But generally, people stay in the hospital for on average around 2 nights. They're up and walking right away. So one of the downsides of the posterior screws is it's more muscle dissection, potentially more pain, but people also get more stability. Therefore, they may have less pain after the surgery, especially like 2 to 6 weeks out, because the screws in the back are so strong, they get more stability. And the fusion has a higher chance of actually occurring, and it may occur faster because there's more stability. So the bone may actually grow faster if you do it from the front and the back, the anterior-posterior fusion. But basically, the outcome and the return to function is about the same. We start physical therapy around 10 weeks after the surgery, and we slowly progress to all our activities. In both cases, fusion typically takes 3 to 6 months and may take up to a year. People generally, I'd say their pain from the surgery generally lasts about 6 weeks. Most people by 6 weeks after the surgery are at least as good as they were before the surgery. Their post-surgical pain, the real surgical muscle pain, has settled down by 6 weeks, and they start to see some of the benefits of having the surgery, especially if they had nerve compression before the surgery. If you take the pressure off the nerves, most people actually wake up and feel that improvement right away. One of the hardest parts as a surgeon is trying to tell people the post-operative recovery course, because obviously everybody's different. We talk about general guidelines and give people ideas of where they stand, but we have 10 to 20% of people that recover amazing, and they come back 2 weeks post-operative and they're like back to work and have no pain and just ecstatic. Then we also have people who are in agony. 10 to 20% can be in agony 2 weeks after the surgery. And there are no studies, there's no tests, there's no way for us to know ahead of time who's going to do great, who's going to take longer. So you really got to plan for both and hope for the best. So fusion's really got a bad reputation. On the internet, you'll see, people who just talk how bad the fusion hurt them and hurt somebody they knew, and they've had 3 or 4 or 5 of them, and they're still in agony. And that certainly happens. One of the downsides of a fusion is you stop the motion of that segment that you're treating, which is good to fix the pathology at that segment. It kind of just obliterates it and gets rid of it. But the downside is it can put more stress on the other levels and other joints, the motion segments above and below, which can increase the wear and tear that's naturally already occurring at those other levels. You can develop pain and issues and nerve compression from the other levels, and then potentially have to have surgery on those. Now, some of that we can't control. Like, you've got to really understand the human anatomy to understand why that happens. If you look at a spine model, you'll see disc, you'll see all these discs in a row with 2 facet joints in the back at every level. Just in your lumbar spine, you have 5 discs and 10 facet joints. That's not a big area with 15 different moving parts that all can fall apart and develop problems. And then you got nerves coming out, 2 of them at each level. So the spine's complicated. It's not for the faint of heart. You can develop problems, even if you never have surgery, you can develop multiple problems that can be agonizing and cause you to be bedridden. So a fusion treats that segment, but it doesn't treat everything. You're always going to have another movable segment on the other side of the fusion. Whether it's your SI joints, your hips, or your thoracic spine, your cervical spine, it never really ends. And that's one of the difficulties of having a spine problem, being a spine surgeon, and after having surgery, you're never out of the woods. You may still develop problems that need to be dealt with. So what are ways we have to deal with that? One of them is, like I said before, is correct the deformity when you do the fusion. We work really hard to make sure we do that as best as possible, because it can help decrease the stress on the other levels to decrease the chance of those other levels falling apart. The overall incidence of people needing a second surgery after a fusion, and the second surgery being at one of the other levels on either side of it, is around 20 to 30%. And those studies have been around 10 to 20-year outcomes. And that's a ballpark number. Obviously, it depends on who you are, a million different factors. But that's kind of the guesstimate. If you said 25% on average, well, it's not a majority. It's not an overwhelming number, but it's a significant number. 25% is 1 in 4. And we do 2 to 3 fusions a week at times. So it happens, and it has to be dealt with. So a fusion is the last resort. We try everything to avoid a fusion. A lot of times we'll do these little microscopic, minimally invasive surgeries of just sneaking in and taking the pressure off the nerves, the same one we do on professional athletes, just to take some pressure off and take the pressure off the nerve, and then do physical therapy, get your core muscles strong, do our back program to take the stress off the segment to avoid a fusion. That's generally what we always try first for the most part. But ultimately, if you need a fusion, if you have biomechanical instability and you have a real biomechanical problem, well, a fusion will fix that. And whereas natural life, just walking around, nothing else really fixes a real biomechanical deformity except the fusion. So the fusion can work. And the results of the fusion and the technology has gotten significantly better than it was 10 to 20 years ago. So the fusion is a solid surgery that helps a lot of people, but it's still the last resort. We try and avoid it at all costs. Our Back Doctor app, and part of the reason why we designed it and why we give it away for free, is because it has everything in there we know to treat back issues, to potentially avoid a fusion and to avoid surgery. Diet, meditation, massage, cardiovascular exercise, the back program, everything we know basically is in there, and in hopes that we can help people, our patients, but even people we don't even know. If somebody in Wisconsin downloads our app and it helps decrease their back pain and they can avoid doing a fusion from that, that's awesome. And the Back Doctor app is free in the App Store and in the Google Play Store. And you can also go to our webpage, backdoctorapp.com, to get information on the app, to see all of our videos and everything we know about different spine treatments, and information on how to contact us for an appointment. That concludes our podcast. I wish you the best of luck if you have spine pain, to get out of it or to help manage it. And if you don't have pain, I wish you the best of luck in avoiding to get it. If we can help in any way, please don't hesitate to reach out.